Shivam, good evening, Shivam.
Good evening, sir.
Good evening, Shivam. Good evening. Where are
Uh,
you, Shivam?
at my home only, sir. So
Is
you
it
have
a...
the background, sir. I shared it with
Yes,
you.
Shivam, I'll change it. Shivam says I listen.
Yeah, thanks a lot, sir.
Good evening, ma'am. Amardeep,
Hi,
ma'am.
Dr. Prasanna. How are you?
Ma'am, good evening, ma'am. All good, ma'am. Thank you
So
for the
good. Yeah.
opportunity, ma'am.
No, thanks. Thanks to you actually
No, no,
for doing
likewise,
this.
ma'am.
It's not easy, yeah, to take out the time, no?
Yeah, yeah, yeah. No, but we are doing it for the passion of teaching and learning also, ma'am. So,
Yeah, it's actually there are so many centers who are not doing it. It's a good idea. So
ma'am, our center, no, ma'am, we trained 13 mixed surgeons last year, ma'am. In
okay,
Trichy, we trained 13 people and uh, I
that
think we are going forward in a very
that's amazing because
pedagogical way.
not all the wet labs they are that effective.
Yes, ma'am. Ma'am, and another challenge is the Godse wet lab doesn't have the angle anatomy that we would really want to, do a
The
MVR blade, nick, identify the
yes,
Clem's canal. Ma'am, the real
yes,
challenge I feel is for suture gap, ma'am, because
absolutely. I
KDB,
agree.
KDB and bang, we see and we just stare. Sometimes we tare it rightly at the novice stage. You may
Bilkul.
be lucky or you may be missing it out here and there, but in suture cat, there is no room for
There is
error.
no scope. Yeah, there is no scope
No
for
scope
error.
for error. So that is why our center suture cat we focus, ma'am. We wanted to it was more like an upgradation center also where we wanted to bring the suture cat training. If
Okay,
somebody says they want to learn upgrade to suture cat and they do KDB and bang very well, or even KDB
okay.
and bang also we started, and touchwood everything is going well,
Yeah.
and lucky to connect with like-minded people like you, Shivam, and
No, we are really interested in this MIGS.
definitely, ma'am. We'll have a good session today, ma'am. I have kept
Yeah,
it very video based, and we'll have a good session.
because most of the people they are not doing it. They'll be just doing it for the first time.
Yes, ma'am. I have kept it very basic from direct gonioscopy point of view.
Okay.
Very simple mistakes, what will happen, how we can avoid things, and
Yes.
very
Because
basic.
even I remember when I started looking for that intraop gonioscopy, I found it difficult. for at least 5 or 6 patients.
Correct.
Now
Correct.
I just keep the lens and I can see it. So
Yes, ma'am. Shivam, how many minutes you want me to have a talk, Shivam? 15 or 30? How do you?
So whatever you want, sir, like you can go ahead, sir, and we'll clear the doubts also on by side. Like
Yeah,
we
you can stop me in between. Like if that particular video you have a doubt,
yes, yes,
I've kept it fully video based, all my own cases, and
yes, yes.
I think we can have a good 30 minutes session or however you say so.
maybe
Yes.
what we can do, you complete your talk first,
Mm.
and then you might have to replay your video parts and bits and parts of it as,
Anything is fine. Anything is
yeah,
fine.
like the when the questions come, so we can explain it
Done,
again.
done. Anything is
Yeah.
fine, ma'am.
Yes.
Extempore also we can do it, ma'am.
Because I know that most of the people will be hesitant to ask any question. So,
Sure, ma'am, but we can have it as a very informal session also. In case
so
if,
we are the ones who are going to ask silly questions. So
sure, ma'am.
we'll start with that.
Sure, ma'am. Sure. In case if you want me
Yeah.
to stop also, I'm fine. That's not an issue. In the sense,
Yes.
stop and have a
Yes.
like a wet lab kind of a
So maybe
discussion.
just one uninterrupted talk because we have the session for complete 1 hour. So one
Done, done, done.
uninterrupted
We'll
talk
do it.
followed by that repeated questions and then again
Done,
going back.
done, done, ma'am. We'll do it. It's after a long time I saw a group where everybody were putting yes, yes. I think Shivam has ragged
Yes.
people to put that. I don't know.
No, we have another doctor with us. She is really efficient.
Okay.
Yeah.
Dr. Sakshi, ma'am, if I'm
Dr.
right.
Sakshi. Dr. Sakshi.
Yeah, I figured
Uh,
out. She was
yeah.
also putting thumbs up for all the
Yes, yes, because when I
responses.
asked, nobody replied. When she asked, everybody was giving thumbs up.
Because today webinars to really bring a good set of people, you have to do a lot of groundwork to get them on. So
Yes.
I'm also seeing Arshi here. Arshi, good evening, Arshi. You're here. Ma'am, we have a glaucoma focus group that you would heard of.
Good
Glaucoma
evening, sir.
interest.
Good evening, ma'am.
Arshi, good evening,
Hi, good
Arshi.
evening, Dr. Arshi.
Good evening,
Uh,
ma'am.
Ma'am, we have a glaucoma gig interest group in Yosi, a brainchild
Okay.
of Arshi and Shivam, and these two are
Okay.
doing phenomenal activity in the YO sector, ma'am, because
Oh,
we were not able to do it during our tenure. We tried to bring something for glaucoma, but I think Shivam from north to south, he's covered everything from
he's covered everything. Yes.
Dehradun to Tirunelveli. He's now
Yeah.
completely he's caught hold of everybody.
Yes.
To certain people, we can't say no, no, ma'am. Shivam is one such person. He's like, sir, you have to
No,
come only.
but what I know of you, you will not say no to anyone.
No, ma'am. I do agree to you, but still,
Huh.
I tried saying no to Shivam, but Shivam made me say yes.
Huh. So
So,
it becomes easier for us then.
sure. We can start whenever you say, ma'am. I'm ready. And
Uh,
Wait for another 5 minutes for a few people to join. I think
yeah,
so.
yeah, yeah.
50 trainers
Perfect.
are our, and we're waiting for
anybody,
Gaurav sir. Gaurav sir
anybody,
also,
uh,
he's in
sir,
OT.
sir said that he'll join in between.
Yes, yes, ma'am.
Yeah, because he might be in the LASIK OT right now.
Dr. Jay sir is in.
Jay must be aware of it.
Yes, sir is in Smile OT, so he will be joining after completing the OT in between the. Uh,
Okay, then we just start by another 5 minutes. We'll wait, sir. No issues,
You
sir.
have a link, Shivam, which you want me to share in the link or any other thing?
Yes, sir. That will be. I will be sharing with you, sir. That our all the conference share links I'll share, sir.
No, no. Now, for now, if you want me to share, I'll share it to people if you want.
No, sir. I want this thing to be very
This to
close.
be, yeah, actually,
Close.
huh?
Mm,
Perfect, perfect. A close-knit group.
so that
Basically,
people.
who are interested, yeah, and yes.
I want
My,
the like, ma'am. Can you by the time can you like welcome our wet lab attendees, like the trainers who have registered for the wet lab. Our
Yeah, I think most of them have already joined.
yes, yes, ma'am. You can just
No?
welcome them, then we'll go ahead.
Yeah. Hi, I'm Dr. Amardeep. This is Dr. Shivam Gupta, and Dr. Prasanna will be taking the talk. And I thank you all for coming, sparing the time and attending this webinar. We welcome you, and please don't hesitate to ask any questions. We'll be opening the session in another 5 minutes. So feel free to ask any basic questions or any doubts that you have. So we are looking forward to a great session. Thank you.
we have already great surgeons who are doing very great works in it, and we are very lucky to have them and like over here. And thank you everyone for this. And we'll be starting by 5 in another 5 minutes.
By 8, I think we should start, right?
Anybody has any doubts before the class or anything want to ask, you can start. And what all, if anybody wants to say something, please, you can have some questions beforehand only. Hello, Shanendra sir, please.
Hello.
Hello, sir.
Good evening.
Shanendra sir, good evening, sir.
Really.
Dr. Vijay Joshi sir is also here with us. We are very senior members with us. Dr. Sandeep Gupta sir is here. Dr. Smriti ma'am, welcome ma'am. Can you hear us, ma'am?
I think they're muted.
Yes, sir. No, ma'am.
We will, yeah.
Yeah, I can hear you. Thank you.
Hi, good evening, ma'am. How are you?
Good evening. I'm good.
So happy that you can join, ma'am.
Yeah.
Yeah.
No, we wanted to do this workshop. I was so glad it was like in Dehradun and we
In
can
Dehradun,
attend it.
right.
Smriti ma'am,
Yeah,
good evening. Good evening, Smriti ma'am.
Good evening.
Good evening, ma'am.
Hi, Shailender. Shailender is my batchmate.
Oh,
And ma'am, I am very lucky to have my PG senior who taught me SICS and everything. She is also joined as a Dr. Dipanjali ma'am. Hello ma'am, can you hear us? Dr. Dipanjali ma'am?
Hello, Shivam. How are you?
And ma'am is joining
Very
from
nice to
Tripura
meet you in
as
the
she
Zoom
was.
meeting.
Yes, yes. She was in my senior in Tripura when I was in Northeast. She was my senior. She taught me SICS and many more things. And it's great to have ma'am over here. Thank you, ma'am.
Thank you.
Another 3 minutes and we'll start, sir.
yeah.
Hope my screen are visible.
Yes, Shivam.
So this is our concept of our program. This is like 4 things in it: glaucoma, of course, and the winter which is going on very cold in Dehradun, and of course we are applying for a surgical carnival. So this is our logo for it, and so this is it.
Although we know everyone, I think before the next session, we can have a small intro by everyone, where they are based, where they're working.
Hello, ma'am.
I think we can start. Everybody is here.
Yes, ma'am. I think so. We'll
Yes, ma'am.
start.
Yes, ma'am.
Okay, so good evening all. We'll start with the introduction of our kind speaker for today, Dr. Prasanna Venkatesh Amesa, one of my mentors and one of my inspiration to be a glaucoma person and to excel in glaucoma, and I'm just following his footsteps. He is currently the research and director and glaucoma head at Mahatma Eye Hospital, Trichy, India. He is a DNB FAT examiner, DNB coordinator, and MEHPL Institute. He has published more than 17 chapters and 55 articles, and he is also editor-in-chief of Tamil Nadu Journal of Ophthalmic Science and Research, and he's the editor-in-chief of Oculus. He's one of the book which he has published. He's the editorial board of the IGO videos. He's the joint secretary of UOC, and he's the chief instructor of many instruction courses in different conferences. And he is recipient of multiple awards and multiple named awards also. And he has done many. He's doing very prolific work in life surgeries also. So one more thing is, sir has started one of his kind on like MIGS training program, which is running in his hospital at Mahatma Eye Hospital. And he has already trained 13, 14, even outside India, people are coming to train with him. So it's great to have you, sir, over here. Over to you, sir. I'll stop my sharing my screen. Please start, sir.
Thank you, Shivam. Thank you for the very kind introduction. As I'm getting ready to share my screen. Share screen. Yeah, I'm just sending you a request to the host to allow me to share screen. Thank you for the host for allowing me to do it. Yes. So here we are for our class on direct gonioscopy for mix. I think we may have to mute a few people. Yeah, thank you. So direct gonioscopy is what we are going to cover today. I had a good pre-class talk with Amardeep ma'am and Shivam, my good friend and colleague. Feel free to stop me in between, or we can also have the discussion at the end, and we'll have it very informative and a very video-based manner. And thank you to the whole Drishti team. Again, my glaucoma brother Shivam, the younger one, he's apparently winning everything. That once I won in the glaucoma for the last 1 or 2 years. So he's the most happening in glaucoma, I would say. And as Shivam beautifully told, last year we had 13 people in our center. We had one from Malaysia and one from Dubai, UAE as well, and for MIGS. So this is something I really passionately do, my teaching. And we do all 6, in fact, now 7 MIGSs with Hydrus. Bang, you see me covered with KDB, Suchagat. I was doing iStent also, that's now not available in the market. ECP, iStent Inject W, Bang, and now the Hydrus. So my journey in MIGS actually started in 2019 in a wet lab, I think, which all of you will be soon doing it next week at Dehradun. Many of you will be having your first wet lab in MIGS, or some will be having, your much awaited one. I was able to do Hydrus and iStent Inject W in 2019, and you can see these are some of my own pictures. I placed the iStent between my 2 fingerprints. That's how small an iStent is. So this is my own hands under the microscope in 2019 to see how small an iStent is in the World Glaucoma Congress. And most of the thing that I'm going to talk today is also published in literature. It's my own paper in the February issue 2023 of Indian Journal of Ophthalmology. I basically use mainly 3 or 4 lenses, and most of the videos will be on TVG lens, the Transcend Volk Gonio lens, the iPrism SX, iPrism S, and the Catena lens. That mostly I use these lenses. And that's just some disclosure I wanted to get, but I don't have any financial disclosure for them. What do you do for an aspiring MIG surgeon? You see what, after you finish your cataract, I predominantly do it after my cataract surgery. I send the microscope to my assistant and he tilts the microscope towards me. So when he's tilting, what did you notice in this region? I'll just come back to it. And after he finishes the tilt, the binocular loop will be pointing towards me. I need to lift it. So that is a very important step. So before and after tilt, you can see that I do a pencil marking, so that I'm not dependent on my assistant. Some microscope has automatic. My Hack Street that I use doesn't have an automatic one. And so I need to have this pencil marking. So this is before tilt. This is after tilt. You can see after tilt, the coinciding line is there. So this is the pen marking. I'm again going back. This is before tilt. After tilt, you notice this particular marker here. In the microscope, it comes and joins the pen marking. So that is 45 degree that I've kept. But as I told you, my dear friends, the binocular loop should be inclinable in your microscope so that you will avoid the eyepiece stooping down. You have to lift the eyepiece upward. Otherwise, you will develop neck pain. So that's a very important point. And after you do that, what do? The patient's head is tilted away from you. Microscope towards you, patient's head away from you, 30-40 degrees. Each, you get a cumulative 80 degree. So what does this make? It breaks the total internal reflection when we put the direct gonio lens. So when we put the direct gonio lens, the total internal reflection is broken, because that is always the principle of direct gonioscopy, or gonioscopy for that matter. So we need to break the total internal reflection so that the angle structures can be viewed. That is the first point that we are seeing in today's class. Practically, we'll be seeing it next week. The second most important point is the patient's head should be above the heart at all levels, so that there is no blood reflex from the Schlemm's canal when we do the procedure. So moving on to this particular lens, the Taunton style stabilization ring, the TVG lens. I am informed by Shivam that we predominantly are going to get Catina lenses in the wet lab. Very nice, which I'll also be having more videos on it. This one particular lens, once you are into your mixed journey, I've started to feel very useful because can you see this clit ring, the sharp thorn-like ring? And the lens is also called the Taunton style stabilization ring. So most of the times I prefer a subtenon's block for my mixed surgeries. I don't prefer topical unless you are absolutely comfortable going with the topical surgery. So when you do a Thornton style stabilization ring under a subtenon's block, it docks the eye with a clit ring surrounding it, and you can move the eye. Why it is important? You'll be seeing it in the next video. Gonio lens docking. And another important sign I tell my fellows and my residents who start early, you have to see the optic haptic junction when you tilt the microscope. So in this point here, I've tilted the patient's head and the microscope, and I'm able to see the optic haptic junction here. That will give you some idea that the tilt is right. And this is the area where there is a block. I hope you are all able to see my mouse cursor. Shivam, my mouse cursor is seen?
Yes, sir.
Yeah, perfect, perfect. So this is the area where I've given my subtenon's block. If you are going to use a lens which doesn't have the cluttering, right, you will not be able to move the eye because the eye is already anesthetized and it's blocked. Now, when I use and I'm putting a HPMC between the cornea and the lens, simple HPMC should be fine. After I put an HPMC, I'm using the lens to dock. And once I've docked, now see what happens. I can move it left and right. I'm just going to slow it and show. See, I'm moving it left. I'm getting more extensive visibility of the angle. And now I'm slowly moving it towards the right. Again, I'm getting good extensive visibility. Moving it to the left, moving it to the right. So when I do advanced procedures like suture GAT or even KDB for that matter, see the amount of angulation I can get. I can get even more than 180-degree axis, sometimes even 220 degrees with these maneuvers. And I'll be able to target maximum trabecular meshwork by this maneuver, which I feel is very, very important. So I personally prefer these lenses. Back in the day when I was doing live surgery, which is no more there, I usually prefer these lenses, which is very, very good. So, okay, you are asking me, I am not doing it yet. I want to do it. That's why we are here today. What do you do? After you finish your phaco, even if it's a simple phaco that doesn't desire a mix, just put your direct gonio lens, whatever your gonio lens that you have, a Catina or an eye prism SX, and just take a Sinskey hook inside and just touch and feel the trabecular meshwork. Because it's a high magnified view. See how we are oriented. How are you oriented in that magnified plane? How much you are able to have control in going and touching and feeling the trabecular meshwork. Because the main important point here that we need to note, as more closer we go to the angle, the more closer we are to the Decimet's membrane of the cornea. And when you have a sharp instrument, a simple wrong maneuver can cause a Decimet's membrane detachment, or even the root of iris is also very close. So this maneuver is very important for a beginner to touch and feel the angle with the Sinskey hook, which I always say for phaco surgeons who are starting to do MAGS, do this, start your journey, and then take it in a very phased manner so that you will have your journey comfortable. Okay, what are the microscopes? If you ask me, any microscope after the year 2000 are very compatible. I've had personal experience with Axe Street, HAR Neo 900, Leica microscope, Provio 8, and Carl Zeiss Lumera 700. And these three work very well. But any microscope after the year 2000 is really very good. Right. Coming to ergonomics and body posture, for phaco, our hands will be more of acute, at elbow. So see on the left-hand side. But for mix, since the microscope is tilted towards you, you will be moving a bit away. Your hands will be obtuse. See the angle at the elbow. If your angle at the elbow is not obtuse, there is something wrong. Very important marker. So I tell my beginning resident and fellows who come to me for training, I have an outside photograph of them. And I tell them you do it in your OR also. If your hands are not obtuse, then means you will not get the enfase view. You will not get the enfase view. Either the patient's head is not tilted fully away from you, or the microscope is not tilted more towards you. That is why you are having an acute angulation. So that means something is wrong. Please tilt either the microscope more or please tilt the head a bit more. A very important sign. So this is what is my own picture. I do it around maybe 135 or 150 degree. I have a tilt when I do my MIGS surgeries. So that's very, very important. And your chair also will slightly recede back. Your chair will recede back and you will also recede back. A very important position in mixed surgery. And so this is one of my mixed surgeries, a suture gad. So you can see my right hand is moving, but my left hand is very stable. So it seems as if the right hand is the surgical hand, but no. The left hand being very stable in the surgical field, allowing my right hand to move is because I am continuously visualizing the surgical field without any distortion. So my right hand can, take instruments, Helon GV Pro, other instruments, Suchagat, whatever KDB you are doing. And another thing is, since we are doing under full magnification, make sure your illumination is as close to 100 as possible. So I would prefer 95 percentage, but keep it as close to 100 as possible. That will help you to prevent loss of light when you have the high magnification. And another very important point is your incision should be in such a position that if you put the instrument inside, I'm not doing the procedure, I'm just demonstrating the overlocking maneuver. From a temporal side, if I'm putting the incision should be in such a plane that if I want to move my instrument from supranasal to infranasal, I should be able to freely move it. See how I'm able to freely move on either side. So the incision should be in such a plane. Also, the incision should be slightly anterior to the limbus clear corneal so that there is no bleeding. So two most important points when it comes into incision placement. And if you do it rightly, the overlocking movement will be nicely done. And now we will put the direct gonio and do the KDB or bang. Right. Coming to foot pedal adjustment. Again, this is one of my own videos. And I kept an animation foot pedal of your leg. So I always tell your left hand, your non-dominant hand and your non-dominant leg, because most of your right legs will be on your phaco pedal. So that defines how good a mixed surgeon you are going to be. Why? Let's see this video. So I have put HPMC, I finished my phaco, I have put HPMC and everything. I'm using an eye prism S lens here. The moment I keep the lens, that's it. Don't remove it. Why you should not remove it? See what happens here. I'm just going back. See how the blood is centrifugally moving outward. Now, if you take your lens again, the blood will come in. So never do it. Okay, that's first important point. I've kept the lens. This is an unedited 2-minute video. And what am I doing in my foot pedal? I'm zooming in, right? I'm zoomed in. After zooming in, I'm going to fine focus up and down. Now I'm fine focusing and getting the trabecular meshwork structures or the angle structures. Now what am I going to do? I'm zooming out. Why am I zooming out? I want to identify the main incision to take the instrument inside the eye. And now again I am zooming in. At any point in time, if you see my left hand, it is just not moving. It is very stable. And the right hand and the left leg is zooming in, zooming out, fine focusing in, up. And now the right hand has started to do the KDB surgery, the Kahook dual blade procedure. I'm not going into the depth of surgeries. I'm just going to keep it very superficial with direct gonioscopy. But see how direct gonioscopy makes a difference, my dear friends. Again, the left hand is so stable, it's like a rock solid stability that allows you to visualize and prevent the blood from coming in. And when you find a resistance, just stop, again reassess, and then do your procedure. That's it. See, it's 1 minute, 12 seconds, totally unedited. I haven't fast forwarded the video. And I'm just coming out now taking Helon GV Pro. When you put Helon GV Pro, a C-shaped, I am again, this is an animation of mine. See this, my dear friends. The blood has to come in a C-shaped manner. In cataract, when you put the visco, it just comes. You put visco like this, blood comes like this. It's a linear pattern. But with the refractive property of the direct gonioscopy lens, see this very closely. You have to put that extra amount of Helon GV Pro or whatever cohesive visco you use. It comes in a C-shaped pattern. It goes and comes like this because of the refractive property of the gonio lens. That extra second you need to give to clear the blood, and see the beautiful mixed cleft that has been created on the inner wall of the Schlem's canal that is seen. And that's it. Less than 2 minutes, a successful mixed surgery. once you master the technique, this is KDB. So at every point in time, what is the take home point you will take from this video is your left hand should be stable and your left leg also should be oriented. Zooming in, zooming out, fine focus. At any point in time, when there is, see the blood flow, if I'm keeping my lens like this and I'm going to remove my lens immediately, the blood will again come into the whole surgical field and it will make it complicated. So the moral of the story from this video is left hand, left leg, foot pedal orientation is very important because you need to know to use your joystick if you want to go for advanced mixed surgeries like suture gap and hydrus. Let's see some practical case highlights. Okay. If you are going to use a lens again and again, a disposable lens like a Catina lens that I'm using, see the reflection, the scratches causing a lot of reflection. Will I be able to see an angle? No. So these are things which I learned in a very hard way. In 2021, when we started the mixed journey, we didn't have much people to really guide us on how to go about things 5 years back. So this is some of my Catina lens that I started ETOing and reusing it. And see, you just can't visualize the angle. So you may be, what we need to understand is you will have to, go for a new lens. So reflection from scratches will be one of the major challenges. Yes, Purkinje image. In Catina lens, you don't have an anti-reflective coating, but with eye prism SX and eye prism S, you have anti-reflective coating. So say this Purkinje image, my dear friends. Sometimes the Purkinje image will go and sit on the trabecular meshwork itself. It's very difficult for beginners, especially, when you don't visualize the trabecular meshwork, the Purkinje image, as you can see in the below, it will be very disturbing for you to do your surgery in the early days. So that's another point, because all these are things which you are going to face, because I think we are going to see a lot of neophytes in wet lab who we are going to train. Right. Another common scenario in anxiety or when you are not getting the view correctly, we have a tendency to give pressure, axial pressure. When you give that axial pressure in the left hand, you will get corneal striations, and excessive pressure axially will cause corneal striations and you will lose the visibility in the angle. That's another very important thing. As a neophyte, we need to be very careful. Right. Another one is with the TVT lens, if you are going to give the same pressure, since in TVT lens, you won't have SKs or the corneal striations, you see the Schlemm's canal collapsing. When I give excessive pressure, see how the line, this tangential parabolic line, see how it is collapsing the Schlemm's canal. So when you give excessive pressure, sometimes the Schlemm's canal will collapse. And in cases like hydrus or an eye stent inject, when you want the Schlemm's canal to be dilated so that you will be able to implant the implant in the right plane, you don't want the Schlemm's canal to collapse. Otherwise, you'll end up implanting, especially if it's an eye stent inject W, you will end up implanting it in a wrong plane. Or if it's an hydrus or a suture gap, you will not be able to thread it into the Schlemm's canal. You will think, what am I doing wrong? I'm able to see it correctly. Why is the suture or the implant of hydrus not going into the canal? So these are some very important tips and tricks, which again, a neophyte needs to know. Managing blood reflex inside and outside the eye is very important. So how do you manage blood reflex inside the eye? Okay, so suppose if you're going to do an eye stent inject W, it's very easy. In eye stent inject, I always tell how you go about it is, once you have gone and touched the trabecular meshwork, you have the trocar, right? Once with the trocar, you have immersed it. Don't double think. You are in the right plane, shoot the injector, because now if you come back, the blood will start to come and you will lose the sweet spot. Once you pierce it with the trocar, go for the implant. Just go for the implant, one shot, come back 2 clock hours away, touch it. Once you have pierced it, don't double think and come out. Again, click, shoot, come out. Then you will see that the blood slowly will start oozing out. If you don't implant and you come back, the blood will anyway come because you have already pierced the trabecular meshwork, and you will find difficulty in choosing a right spot to place the implant, especially in eye stent inject W. But injectors are quite easier because you go and you place and then you come back, and there is not much of blood that you need to manage. When you do suture gap or KDB or bang, when we put the MVR blade nick, you can see I'm putting the MVR blade nick, then the blood really comes into play. That's the challenge. you have to use Elon GV. I use Elon GV Pro. It's a strong cohesive viscoelastic, hyperviscous. It just displaces the blood. I told you, that C-shaped pattern. Just keep it in mind. It clears off the blood. Then I start threading my suture. So the more you start threading, sometimes the blood tends to happen again and again. And again, you have to be patient. Put more sodium hyaluronate, Elon GV Pro, clear the thing, and then keep threading. See, I'm just putting again some more Elon GV, clearing off the field. You can just see here, I'm just clearing off the field here, putting Elon GV Pro. Again, clear it, again, then thread it, and to identify whether you're in the right plane, you can see the sutures blue line to an extent here, and you can dock the lens a bit to the left to check whether you're in the right plane. So these are some another important tips and tricks. Or you can remove your direct gonio lens, tilt the microscope and the patient set back, put indirect gonio lens and see whether the suture is going in the right plane. That is another way that you can do, which I learned from Swati ma'am in Pondicherry. And these are all very efficient ways of going in. Shivam, is my voice audible?
The voice is over and the slides are going good, sir. The
Okay,
videos are
just
good.
had a comment that the voice was
Yes,
not,
somebody said that the voice is not coming.
but I think the network issue should be in their side, I believe.
Could
Yeah.
be because we can very clearly hear you.
Perfect. Let's keep
Yeah.
going.
Yes, sir. Are you able to hear now, sir?
Perfect.
Yes, sir.
I'm able to hear.
Okay,
Yeah.
sir.
Oh, thank you.
Thank you. Let's keep going. So in suture GAT, we were at a point where, either you use a TVG lens, just tilt it and see whether the suture is going rightly, or remove the direct gonio, tilt the head, tilt the microscope back to normal and put an indirect gonio and then see. Then after the suture has come 360 degree on the other side, just take an MST forceps, catch hold of the suture, bring it out gently, slowly through the main incision, the trailing suture, and then the leading suture will be brought out of the main incision, and the trailing suture, you just pull it like this. It comes the ab interno gonioscopy assisted transluminal trabeculotomy, where you do a complete deroofing of the trabecular meshwork from inside using a simple 50 Prolin suture. That's it. So this is how you clear the blood. There is another blood where the blood can come between the lens and the cornea. And I particularly take this photo image on the outside as well. How we see what happens. There is a blood coming. Okay. In a high magnification, when you start in early days, you will not know whether the blood is inside the eye or outside the eye because you are working under high magnification. What mistake I am doing? I'm telling the sister to clear the blood on the cornea. That alone is not enough. The blood is actually on the lens also. So again, I'm doing the same mistake, and that blood is causing cornea also to get the blood. Now what am I doing? I'm telling the sister, look at right hand side. I'm telling the sister to clear the blood on the cornea and the lens. And now when I'm going and putting the direct gonioscopy, the problem is solved. Very simple. But all these mistakes, we do it in our early stages. So the blood can also be outside the eye. The blood can also be on the cornea or on the lens. Make sure you clean everything and then go back to your surgical field when you face a difficulty. That is another point. Once you have mastered, these are basically the very common mistakes we make in our early days. Once we have mastered this with eye prism SX, you don't need to use both your hands. You can use handless technique, and you also have the gonio ready. Oculus gonio ready is there, and many other lenses are now coming with hands free. And this was one of my live surgical cases where I did the surgery with hands-free technique. That much of a confidence, these lenses give so much of coupling effect that you can, you can see again, you can count on it. And mostly for suture GAT, you will need both your hands free so that you will be able to, do well. So that is very important to keep in mind that for suture GAT, if you have both your hands free, you will feel more comfortable. And coming to some of post-mix angle, I'll just quickly rush through a bit. After you do your surgery also, you need to keep assessing the angle, how it is. There's one paper from our center where we found that in KDB, we published a W sign. The image B is a W sign. In C, you can see in bang, you had a remnant of a trabecular meshwork. And in figure D, we had the bird beak configuration in suture GAT because you just tear it, right? The suture just tears it. So you'll have a bird beak kind of a configuration. This is how it looks in suture GAT, a typical bird beak kind of a configuration. And I believe Anterion is the imaging when it comes to imaging the angle. Nowadays, Kessia is also there, but maybe I have a bias towards Anterion. And the post-angle dynamics study really helps, and we have come out with a paper, and all the signs we have come out from our center on it. The W sign, the bird beak configuration in IJO published 2024. And also recently we have a study which is due for publication in the month of February, SCIBI, Suchagat, first of its kind study, where we compared 5 mixed surgeries, Suchagat versus KDB versus iStent versus Bang versus iStent Inject. And I'll just share the quick results of it. Uh, we felt Suchagat was very good, followed by KDB and iStent Inject. And Bang and iStent did not really work. iStent is now not available in the market. Bang is something that I don't prefer. I prefer a KDB instead of a Bang because we had a lot of we had a failure rate of 26%. And this was the inference from that study that we felt Suchagat and iStent Inject groups demonstrated very good IOP reduction, with iStent Inject having very less complications. But again, they had more AGMs demand compared to the Suchagat group. And the next promising alternative was KDB. And this is ECP that I am using. In ECP also, I make it a point to first view the angle. I go and view the angle anteriorly above the iris first, and then go behind and do the ciliary body procedure, and then come back again and see the angle. Whether, mostly in plateau irises, we have this sign where the ciliary body shrinks and opens up the angle. So I have this SOPs in place for my ECP cases as well. You can also view the angle with the endoscopic probe as well. So this is how I'm demonstrating viewing the angle with endoscopic probe. And coming to the last fag end, we have a surgical simulator at our center. It was the first mixed simulator, according to my knowledge, again published in literature as well. We wanted to do something for mixed training in a very economical way, but at the same time give a real world perspective to the neophytes. And our center, we have this R&D department called the Mahatma Center of Moving Images. It's a startup as well, where we used simulative training for our residents and fellows. So this is a mixed simulator where you can go and place iStent multiple times, not once, but multiple times. If you are in the right plane, it turns green. The marker turns green. Why is this needed? Because for hand-eye coordination, continuously high magnification, going and doing the hand-eye coordination. Because the 2 or 3 deadly combinations that I don't want a neophyte to do is peripheral corneal descendants membrane detachment, through and through penetration through the limbus, because at the angle you are very close that you can cause a perforation, and the other one is putting a nick in the wrong incision causing an iridodialysis or opening up the suprachoroidal cleft. So these are all these things that I don't want a neophyte to do. So I'm very particular about the cognitive hand-eye coordination under high magnification. And I think with these training, again published by us, it really makes a lot of difference. So coming to summary of today's class, or rather a workshop in an online manner. Topical, yes, you can still do mix in topical, but for neophytes and beginners, always go for retrobulbar block or a peribulbar block. It builds your confidence and it avoids potential intraocular complications. Temporal approach is the way forward. Mix it with your phaco, especially temporal surgeons. Rotate the head towards away from you. Rotate the microscope towards you, and certain endpoints like align the coaxial light along the iris plane. That is another important marker you can keep in mind. So meaning the patient's head is rotated away, right? So the coaxial light can be aligned to the iris plane or optic-aptic junction if you are able to see, which I showed you in my videos. Increase the magnification, increase the light intensity so that you will have a good visualization. And there are many lenses. Use the lens which works well for you. We have TVG lens, we have the Catina lens, we have the iPrism S, iPrism SX, Catina hands-free. We have a lot of lenses. We have one advantage with the VVG or the TVG, the whole transcend old Gonio lenses. X, Y, you can have the fixation ring in the X and Z axis, you will be able to rotate. That I feel gives a lot of additive advantages. And mix is not an alternation to filtration surgery. We talk mix in almost mix is something that still has its glamour. When it came in 2021, at least in India after COVID, it took the glaucoma sector by huge noise, and still is. It's still making a lot of impact. So I think MIGS is not an alternation to filtration surgery. Choose only the optimal candidates, and it is doing something what anti-VEGF is doing for retina. MIGS is doing the same thing for glaucoma as what I would coin it for now. And with Suchagat, I think we are slowly moving towards moderate to severe glaucomas as well. Because initially we were doing only for mild to moderate, but now with Suchagat, we are getting good amount of IOP drop, and slowly we are shifting towards advanced cases. And these are some of my studies on MIGS, which really put me on the global plane. And this is one of my studies cited by stalwarts from PGA Chandigarh, Professor S.S. Pandav sir in the World Glaucoma Congress. You can see Shamira Pereira and other stalwarts on the dais. And these are a group of people I really am very blessed to be associated with. And Dr. Tanuj Dada sir and we have come out with a lot of papers, a lot of articles. Some of my original works is predominantly devoted to angle-based surgeries. And this is one of my work that I published in AOS along with Dr. Tanuj Dada sir. And the one mix that is recently doing the talk is again Hydrus. Again, I just wanted to end with this video because I was the third surgeon in India to do, first in Tamil Nadu. And you can see Hydrus again, it's a very promising angle implant, next gen implant. It dilates the canal. You can see it. You need to have a good understanding of the anatomy of the angle. And I feel if you are a suture cat surgeon, Hydrus is very easy for you because just like how you are threading the suture into the angle, now you can see me threading. I'll just go back again here. You can see how I'm not moving it. I'm just rotating the lever and automatically the implant is getting threaded into the angle. And I feel a suture cat surgeon will have Hydrus implantation very easy for him because he threads the suture 360-degree. In Hydrus, you just need to do 90-degree. And that's it. I think this is the next generation mixed teaching canal-based outflow enhancement. I think we'll be having the Hydrus discussion in Dehradun as well. I think Shivam has given that topic to me. And so Hydrus is something which is up and coming. And these are some of my candid pictures. I take pride in connecting with people, Dr. Shamira Pereira, Dr. Vanita Pathakre ma'am, and of course my glaucoma brother Shivam. And again, thanks to sir for Gaurav sir for the opportunity, and Drishti team, Amar ma'am, Amardeep ma'am. And these are all my students now in all parts of India and two of them outside India as well. I take pride in teaching and empowering a lot of mixed surgeons in all mixed surgeries. Now 7 mixed surgeries are there. And our center is training all of them. These are all just the people who trained last year. And we also had the Malaysian Glaucoma Society Secretary, Dr. Pushpa Raman, who chose our center last year for mixed training. And especially for Sucha Gat, she came. She does a lot of implants. They were not doing Sucha Gat, and we take pride in teaching them. And again, this is one of my students, Dr. Shivani. And these are all her videos when I was training her in mixed surgeries. So she's currently practicing in Indore. So if you guys reach out to me at Instagram, you can. I'm very approachable on social media, email ID, WhatsApp, and my researcher ID. So I think with that, we come to the end of the formal slides, the so-called slides. The forum is all open for discussion. I think I just took 3 minutes extra, Shivam. Apologies for it.
No, sir. Like we should have been I was also noting down many points in between. It's still
Oh,
no the number of times I see your presentation, I'll get something new only. Like so, every time I take this time I made sure that I have a paper pen ready with me so that I can make sure that all the points I have included in it. And it's nice to have it very detailed. So we'll start group is open for discussion for the participants of the wet lab. Please, can you go ahead asking your doubts? Dr. Vijay Joshi, sir, can you hear us, sir? Hello, sir.
Yes, yes, I can hear you.
Sir, go ahead, sir. Hello, sir. Very nice to have you, sir. Sorry for the audio lag in between. I think we had some audio issues, sir.
No
Sir,
problem.
sir, any doubts what any you want to ask, sir? Dr. Prasanna, sir, is here for you, sir.
No, I just want to ask about the hypema management in AC during the procedures. So it will be a long to take it. I will be taking it 1-to-1 when we'll be meeting him at Doon.
hello, sir. Vijay, sir. Nice to see you again virtually. I think we are connected on the WhatsApp plane. Just a quick,
Exactly, sir.
since you mentioned about IFEMA, sir, I think for the benefit of our attendees as well in this particular forum, I'll just quickly show two images. These two are my worst cases. The best cases are head and elevation. I put ethamsalate, and ethamsalate really works well. Just a minute. So I put head and elevation, ethamsalate, and it really settles down well. Two of my worst cases is something that I'm just loading my other slides as well as we speak for the benefit of the attendees here. And those two also settled. So I'm just trying to get it loaded. One was managed conservatively, and other one, it was very organized. It was a very, very organized hyphema, and I had to take literally a phaco probe into the eye and had to remove it because I tried removing it with an IA probe. I tried my best and I was not able to do it. I had to literally take the phaco probe in and then do it. I'm just trying to load my slides. I'll just share it as and when the slides get loaded. Yes, sir. That's one thing I just wanted to add when Vijay sir was just
And
pointing.
secondly, sir, you talked about the intraop complications like the iododialysis and hyphema, other things are there. But how you take care about the post-op complications?
Sir,
My battery is
ideally,
low.
you're audible, sir. Sir, ideally, you should not have any other complication except IFEMA once we have mastered the surgical procedure. Because the main complications that a neophyte will be having is either they will have an epithelial defect, because what happens now, sir? They do the direct gonioscopy. They will try to find the main incision to take the instrument inside, and in that inadvertently they'll be scratching the epithelium and they'll be going outside the eye, epithelial defect, or they will be damaging the incision, the corneal incision, the phaco incision that we put. That is another one. And other complication which I have had in my hands during my early stage once is under that high magnification, the subincisional iris, you won't be able to see. If you take a KDB blade, which is very sharp, sometimes you full and full through, you put a PI, an iatrogenic PI through the subincisional iris. So these are the possible complications you can have at least once or twice in your life, not more than that. You have to then identify that, okay, these things should not happen. Or as I told, in the angle, the cornea will be like this, the iris will be like this. You will be very close to the Schwalbe's line, which is the termination of the Descemet's membrane. Especially in suture gap, when we try to pass the suture, we will be so immersed in passing the suture that will inadvertently slightly cause a DM touch. These are the things which can go wrong, which are all slightly skill based, which should not happen after maybe a nascent stage, maybe once or twice in when we start doing it and we burn our hands. We should just make a note of it and just prevent this from happening again. Otherwise, it's only hyphema, sir. Apart from hyphema, we don't tend to, and I've just loaded those images. So this was one of my worst case scenarios, which I'm publishing soon as well. So this was one IFEMA that was just not settling, and I tried conservative management, and you can see it slowly coming down with Dimox, ethamsalate, maybe some topical AGMs as well. And then it settled as a fibrin membrane, obscuring the vision. So I had to do an anterior YAG membranectomy to make sure that the patient is happy, because he was complaining that after the IFEMA settled also, I'm not able to see. And another scenario was this IFEMA. I literally had to take the phaco probe inside and had to debulk the IFEMA. After 5 days, I waited. The IFEMA was settling. With IA probe, I tried. It was just not coming. And I had to take a phaco probe, and you can see the white yellowish tinge in the core of the IFEMA. And I had to do it and finally take it out. So these were my two bad cases in the 5 years or so since 2021. And otherwise, patients come with hand movements. They come with, after the surgery, I lost my vision. Nothing will happen, sir. Reassurance, tablet ethamsalate, the tranexamic acid one, and I think that's it. With the Dimox, topical AGMs, head and elevation, things will easily settle, and you may need Predfort and homemade also in these cases. Yeah, I think we
There
have
are certain questions in the
the
chat
chat
here.
box.
Yeah.
OVD for AC in over cornea, same. Okay,
Asta,
what?
can you just open? You can ask your question. Can you unmute and ask your question, Dr. Asta, please? Dr. Astha, ma'am, please. Are you there, ma'am?
Hello,
Yes,
am I
yes, ma'am.
audible?
Yes, Dr. Astha, ma'am, please.
Okay, good evening, everyone. My question was, sir was telling he was using halon for into the AC, but can we use the same OVD for over
Yes,
cornea also, between cornea and the lens,
you
or
can use
should
it.
we?
You can use
Oh,
it. I've used it. Only thing is finances, to be very honest. Elon GV Pro is 3,000 rupees. So the thing is, even with an HPMC also, you will be able to see well. When you use a
okay,
Elon GV Pro, you want to make Elon GV Pro reserve it only for intracameral because of the finances involved. If you end up wasting one Elon GV Pro, then you will have to open up another Elon GV Pro. That's the
yes, sir.
very candid answer. You can use it if you feel you are comfortable, but finances keep a tap of it. That's the answer for it. Otherwise, HPMC also some surgeons use it intracamerally. See,
Okay,
why
sir.
I use Elon GV Pro is again no financial disclosure, is because the personal advantages I felt is I've had a dropped stent. I'll just see if I can load that video as well. So when I've had a dropped stent in the eye, the Helon GV Pro is so cohesive, hyperviscous, that the stent just stays there itself. It doesn't fall on the iris, or it doesn't, slide into the iris and go into the pupil. Or when there is a bleeding, the
Yes,
Helios
sir.
DV Pro just, it's like a bolus of cement. It just pushes the blood away. The field is
Mm.
so clear that you are able to do a wonderful job because your visualization is too good. So these are some of the main reasons, Dr. Asta,
Yes,
hope I'm pronouncing you correctly. We are
yes, sir.
using the Helon GV lenses. The only reason is because of this. So I'm just loading the dropped stent also. I mean, I kept my class today very basic. I didn't want it to be advanced, but there are reasons why I'm using the way I'm using. I just wanted you to also see it. So people talk about dropped eye stents. Sometimes these happens when we had our eye stent journey. Again, we had this in 2022, 2023. Not much guidance were there, and not many surgeons also, in India were also doing it. So those days when I was using these cohesive viscose, it gave me a lot of confidence, that even when you drop a stent, it just stood there. Why it stood there? Because of the viscoelastics that I was using. Just see this video. I hope my screen is visible.
Yes,
Okay.
sir.
So I'm trying to place an eye stent and it is under implantation. And see the stent has dropped. Can you see? That's it. This is the maximum drop. And now I moved to implant the other stent. Okay. The stent will just stay there only. It won't slide and come and fall into the pupillary area. Are you able to understand what I'm trying to convey to you? The Helon
Yes, sir.
Pro will create a good cohesive cement-like environment. And this case, it took me 15-20 minutes to do. I'm just editing it and showing it here. That dropped stent stood there till the whole time that I completed implanting my second implant. It just stood there. See, it just stuck there. The Helon GV Pro sticks it. And now I'm picking up it and I'm going and implanting it in the other plane. So that's the additive advantage that it gives me. The OVD inside the eye is Helon GV Pro. I don't use it outside because of the finance. Yeah. I think we can,
Okay, sir.
your
Got
question.
it, sir. Thank you.
Perfect, perfect. Sandeep, Dr. Sandeep is there, I
Dr.
think. Next.
Sandeep, sir, can you please unmute and ask your question, sir, please?
Good evening, everyone. Sir,
Yeah.
I am just a beginner for the MIGs. No? I am just
Okay.
studying them, and which lens will be the best lens for us, for just like big beginners? Because जो walk surgical gonio lens है, basically, eh, they have written that it can show the angle in the primary phaco position too. Is it better or someone एक care group का आता है सर, basically glucose eye prism SX
Sir, my
disposable lens, which will be the better?
so my suggestion is keeping economics in mind because the TVG lens comes close to 90K. So it doesn't make any sense investing day one into TVG lens. My suggestion for
Sir,
beginners is start with iPrism SX or iPrism S or Ketina.
sir,
They all are
sir.
equally placed around 5,000 to 7,000.
They,
Once we get adapted to these lenses and you start,
sir, sir.
seeing yourself as a mixed surgeon, that you have your volume, you have your patients now, you are doing more volume, then slowly
Right, sir.
put in a TVG lens. Start with
Right,
the
sir.
iPrism S,
Right,
iPrism
sir.
FX,
Yes,
Catina
sir.
or Catina hands-free. They four lenses are the very economical lens. Then
Sir.
move towards Swan Jacob or a TVG lens. That's my answer.
Right, sir. Right, sir. Thank you, sir.
Simply because
Thank
of the economics part. There is no
Right,
point
sir.
in buying a lens for 1 lakh and then, first see yourself in a very phased manner and then move forward. Yeah.
Right, sir. Right. Thank you, sir.
Thank you. Thank you, sir. I think we have Dr. Daisy next.
Daisy, can you unmute and ask your question, please?
Think we don't have Daisy here. Okay. Yeah, I think I'll just shoot the.
No, I have
Oh,
few
yeah, shoot,
questions,
shoot.
Dr. Prasanna.
Please, ma'am, shoot.
We
Yeah,
should be
ma'am.
able to see the optic haptic junction before we like it gives us a fair enough idea. So
Yeah.
that means you are not using pilocarpine in most of the patients or any
No.
of the patients?
No, ma'am, I don't use pilocarpine simply for the reason because I have my explanation in a way. I always believe the ifema and the inflammation will happen. With pilocarpine intracamerally, I feel the blood aqueous barrier can even be more broken and more inflammation is something that I associate when I did use pilocarpine. So
Okay.
after a few point, what I realized is the cornea is like this, the iris is like this. When I use a Helon GV Pro, however dilated the pupil is, or even in terms of angle closure cases also, the Helon GV Pro is so cohesive, it goes and pushes the iris and makes it concave like this.
Makes it space, yeah.
So even if the iris is so dilated, the concavity is able to be achieved. So all I want for my mixed surgery is the concavity that I want because I need to access the angle area. So once I achieve the concavity, I don't really need pilocarpine because I'm achieving the concavity. So that is one of the reasons why I don't use intracameral pilocarpine. Similarly, 90% of my cases post-operative also I don't use pilocarpine. Again, in terms of inflammation. In some cases, if I feel, especially when I was doing my G1 implants, I had a tendency that they may go and touch the peripheral iris and they may cause a PAS. Those were the times with implants, eye stent especially, I was putting some pilocarpine because those surgeries you won't have any inflammation, any ifema, just a few sprinkles of blood you'll have. So those cases I was sometimes you have this configuration, no? You feel that the peripheral iris may just go and occlude the eye stent.
Yes.
Only for my eye stent implant cases, I was very particular and I was more like an OCD that I don't want it to go and occlude the implant. I was putting post-operative pilocarpine. Otherwise, I am a more no pilocarpine person, ma'am.
Even for hydrous? Even for hydrous also?
Hydrous, I'm contemplating putting pilocarpine because
It's a
though
bigger stent, yeah.
though it is the 90% of the implant is inside, the one snorkel is outside, no ma'am. So that particular area alone, I don't want the
Can
iris
be,
to
yeah.
go and my only thing is that is my school of thought in implants. That's why I'm more of a pilocarpine guy when it comes to implant. But for
But
KDB
otherwise,
bag
no.
and suture cat, I'm not really into that. Yeah.
You think? I have few more. What
Yes.
about staining the trabecular meshwork to have a
Uh,
better view?
I did try that, but at least in my hands, it did not really make much of a difference because in Indians, mostly the trabecular meshwork is quite pigmented and it stands out. So I was not able to give any extra additive, uh,
Any benefit, yeah.
extra benefit. So I did try all those things and then finally I felt it did not make much of a
Because I
difference.
tried in two cases. Once I did like phaco with MIJs. So I put in the initial thing to stain the TM, but by the time the surgery ended, that it has already washed out. And the second case, as you said, the TM was
Yes,
already pigmented, so it didn't make much of a difference.
yes, ma'am. Yes.
Yeah. And any particular incision size you prefer? Like if you're doing surgery with 2.2, do you want to enlarge it for that O
I
effect, or
just
do
saw
you
that
want to?
question also, ma'am. Ma'am,
Yeah.
actually, in a way, my question would be slightly answer will be paradoxical. The overlocking maneuver that I am very particular about, especially when it comes to excision devices or even an eye stent where I want one implant here and another implant here. So this overlocking maneuver, if the incision size is more, you get more freedom.
More freedom, yes.
Yeah, so if you are basically having a 2.8 mm incision, you are fine. But yes, the chamber will collapse. When will the chamber collapse? If you're going to press the posterior section. So make sure you don't press the posterior section. Just like imagining doing a rexis through the main incision in an SACS.
Yes, absolutely.
So I would say that to a beginner neophyte, that when you are doing a rexis through the SACS main wound, you have to be very careful that you don't press the posterior lip, otherwise you will collapse and the chamber will slow. Then again you'll have to. Still, many people are preferring doing rexis through the main incision in phaco
Some
also.
people do, yeah.
Yes, ma'am. So similar thing. Do not touch the posterior lip. The incision will just not matter. So I have done few cases with SACS and mixed procedures. In our place, it's a rural area, and some of the patients still have rigid IOLs, our DBCS and CAM patients. So even in those patients with a big wound, I think what makes the difference is you not pushing the posterior lip, and also the small amount of Elon GV Pro if you are able to use. It's not about the chamber collapsing. It's about the angle
Pressing the,
area and the iris concavity. As long as the iris is concave because of the Helon GV Pro that you have used, you don't need to worry about the chamber that is proximal to you. The chamber that is away from you, if that is formed, you can just keep going with your surgery.
So you're doing temporal SICS with MIGS or?
Temporal phaco, ma'am. Instrument phaco.
No, if in case you're doing SICS with the
temporal.
temporal.
Temporal. Yeah.
Right. Thank you.
So, Dr. Daisy, can you go ahead with your question?
Yeah,
Dr.
Daisy had a question. Dr. Daisy.
So I'll
Can you please elaborate about the Schlemm's canal, the collapse of the Schlemm's canal?
Yes, I will do it.
You said that.
Yes. So what happens, Dr. Daisy, when we give axial pressure inadvertently, because we are not left-handed people, mostly we are all right-handed surgeons. So we need to start training our left hand. So inadvertently, when we give pressure on the axial pressure, Schlemm's canal will collapse. When the Schlemm's canal collapses, the Schlemm's canal is exactly behind the trabecular meshwork. Okay, so when we put the nick incision, we want the inner wall of the Schlemm's canal to be seen at the end of the surgery. Okay, so when you put a nick, you may end up putting it in a wrong plane, or when you keep an implant, you may not keep the implant in the right plane because the Schlemm's canal anatomy is distorted. Or if you want to do a suture gat or a hydrus, you may not able to get the implant or the suture into the canal. So the Schlemm's canal not collapsing is a very, very important point, especially for hydrus and suture gat. For KDB and bang, if the Schlemm's canal collapses also, you may get through it, but the incision may not happen in a right plane, in a right planar region. So how do you prevent the Schlemm's canal for collapsing is what we should think. That is by putting axial pressure on the cornea. This is very important because disruption in the anatomy will prevent us from doing the surgery in the right plane. So that is what is the end point of this discussion. So we need to prevent the Schlemm's canal from collapsing so that we get a good optimal end point in surgery, and we want to have better results. See, just because I do a KDB, just because I do a bang, doesn't mean the results has to be fine. We have to do it in the right way. We have to visualize the blade entering into the trabecular meshwork and then doing a goniectomy, And when you enter nicking the trabecular meshwork, you're actually entering into the Schlemm's canal. You don't want the Schlemm's canal to collapse at that point in time. It should be, at least not dilated, at least it should be in its normal plane. That is why the Schlemm's canal anatomy during the surgery is very important for successful outcomes of the procedure. Hope I didn't confuse you, but it's a very important point.
Can you show the picture once again?
I'll
the
do
one
it.
you showed in the.
I'll do it. I'm just loading my slides again. If we have any other questions in between.
Yes, Dr. Nutan, ma'am, any question, please? Dr. Sakshi, Dr. Swati is there. Dr. Meng sir is also here with us. Dr. Meng sir, if any doubts you have, sir, please.
Yeah, I've got the video. I'm just sharing my screen again. Yeah. So see here, I'm put the red arrow here. This is the trabecular meshwork and the white scleral spur is below it. And this will look like a parabola or an horizon, like a black hole, okay, like an horizon. Now, when I'm giving pressure, axial pressure, see how the canal, can you see the canal has now started to collapse here? See the line here. Can you see the line waved, Dr. Daisy? Are you able to see it?
Is the thing has you can see the space has decreased.
not only the space, can you see the curve? This curve should not happen when you're doing the surgery. See, I'm again going back to the starting point of the video. Can you see
Okay,
a parabola which is curvy linear, like a
Yes.
rexus, curvy linear? This curvy linear line is now lost. Can you see the curvy linear line is lost?
Yes. Yes.
Now, when the curvy linear line is lost and I'm trying to do a KDB by trying to slice it, there is a chance I may start in a right plane, but I may end up slicing in a wrong plane when I complete it. Are you able to understand the concept that I'm trying to put here? So that is what I'm trying to put here. So I may try to do it in a right plane, but may end up doing it in a wrong plane. So that is why a Schlemm's canal collapse should also be seen that it should, I mean, when you're doing your procedure, make sure that the trabecular meshwork is seen curvy linear and not curved like a wave. That means there is something wrong. That's the point of this
Thank you.
particular slide. Yeah.
Dr. Shailendra sir, your doubt, sir? Dr. Shailendra sir, any doubt, sir?
Good evening, everyone. This is a totally new topic for me. I today just had introduction to the new procedures, and I'm looking forward to the wet lab. Will be there.
Yes, sir. Thank you. Thank you, sir. Thank you.
Dr.
Hello.
Smriti? Yes, sir. Dr. Mayank sir. Hello, sir.
Hi, Shivam. Hi, Prasanna.
Hi, sir.
Just a question. The tsunami can will collapse on action pressure, but if you release the action pressure, will it reopen just like previously, or it will not reopen?
So there is a fine line. So I'm putting axial pressure more because I'm trying to get the sweet spot. As a neophyte, I'm speaking. Now I'm trying to release the pressure. But if you release too much pressure, and if your lens detaches from the cornea, the blood will come into the surgical field. So there is a fine spot where you touch the cornea, but you don't touch the cornea. So that spot is the sweet spot as a mixed surgeon we need to master. So you touch the cornea, but you don't touch the cornea. So you touch the cornea with the lens in such a way that you are visualizing the structure and the blood moves away and doesn't come into between the lens and the cornea. At the same time, your force that you want to transmit doesn't get transmitted onto the cornea. Otherwise, it will get transmitted to the periphery and it will cause the Schlemm's canal to collapse. So this is the whole principle, sir. That is why the sweet spot in the left hand makes most of the difference for your surgery. In mix, if you ask me, 80% it's your left hand surgery, but we think right hand is operating, but right hand is only 20%. I think that's how I would answer to your question, sir.
Right.
I have one more. Sorry, please go
Yes,
ahead.
ma'am.
The
Dr.
video
Mayank
which
sir.
you showed where the blood was there between the lens and the cornea, what was the source of the blood? Was it the conjunctival bleed happening due to phaco wound?
Two things, sir. I'm a subtenons person. Sometimes most of my cases I do it on a subtenons. I do topical as well. When you do subtenons, you never know how the bleeding. Sometimes the blood gets its access to the subincisional area also, from the conjunctiva. Or despite all your efforts to put a clear corneal incision, sometimes some amount of blood, if there is a superficial vessel that is there or something, there may be some amount of bleeder from your phaco incision also. That will be the sources of blood. Yeah.
Yeah. How frequent do you check your success of the MIGS procedure by putting TM at this trypan blue at the end of surgery?
Ma'am, trypan blue, I did try it, but I don't really see that as to be that as a marker yet, because we have to try trypan blue before and after, because see, ideally, physiologically speaking, a glaucoma patient, even if there is trabecular sclerosis, it doesn't mean there is going to be 360 trabecular sclerosis.
Absolutely.
It's a more flashy concept is what I would still see, unless there are some solid papers coming out. Because if you are Trypan blue, you are using it before your mixed surgery, then you do your mixed surgery, and then you should compare it after your mixed surgery, whether there is any extra amount of Trypan blue that is actually coming. Sometimes even in our cataract surgery, if you try to see also very closely, you may see Trypan blue coming out through the
Normally.
thing. So I still feel it's early days, but I've seen paralimbal blanching in Suchagat the Antrack sign that one Davinder Grover sir demonstrates. When he forms the chamber, you will see a tram track blood just going there. These are some of the signs. I'm very convinced. The paralimbal blanching, the Antrack sign, and other things. Tryptophan blue, it's still maybe if somebody comes out with paper, I think Arvind Pondi is working on it. It's just that
Okay.
I'm not fully convinced on that particular concept. I'll be convinced if we do it pre-mix
Before.
and then post-mix, because then it may just be a patient who just had it and we are just thinking it opened up because of our mix surgery. Yeah.
And to begin with, like KDB, if we say, so like this eye stent and everything which we prefer in the inferonasal quadrant.
Mhm.
So would you recommend to do in the same quadrant if we have somebody in the initial phases trying to limit it for 2 to 3 clock hours,
One
or
in
whatever they
the
are comfortable in the nasal quadrant?
Ma'am, first eye stent inject case, just go in and make sure you place both your eye stents, because you'll be having tremendous amount of anxiety. I still remember my first
It's
eye
very
stent because
expensive.
the rate plays on your mind, ma'am. At least eye stent
Absolutely.
inject.
Yes.
I remember my
Yes, sir.
first case in 2022. I just went in. I had only 1.5 clock hours of difference when I kept my both inject Ws. But after that, once you have done with your first case, you will now know the configurations, and it is one of the most easier mix surgeries to do. It's just 30 seconds. So after that, I think you should analyze it. Only step that I tell people is after you uh, inject your trocar into the trabecular meshwork, don't try to withdraw and reassess, because I think we are having a glitch. Because once you
Yes.
puncture the trabecular meshwork and you come out, the bleeding will start to happen sometimes. So analyze, identify your meshwork, punch it with the trocar, click, come back, release, then reassess. So
So
it's
I think
again,
I didn't frame my question properly. What I wanted to ask, like
yes,
in
ma'am.
eye stent, we are injecting in the inferonasal quadrant, right?
One in the inferior nasal, one in the superior nasal.
Yeah, but like for KDB, if somebody has to begin with, so shall they focus on the inferonasal if they're trying to limit, or anything in the nasal quadrant? If they're trying to limit to 2 to 3 clock hours.
Ma'am, to start, if this is going to be the V-shaped nasal angle that they are seeing, I tell
Yes.
them you focus on the smaller V for a beginning. You focus because these peripheral V's, again, you need to do some joystick maneuver to focus, fine focus. As you move towards your periphery, your microscope, your joystick has to move, your fine focus has to move. Some more visualization difficulties may happen. So have your V like this. Start from your right side, move to your left. That's how we all find it easy, because that's how we do the Rexes, most of us. So do it, have your V. With time, you will see that your V starts to
V is
increase.
explained.
It starts to increase, and without knowing, slowly start another case slightly away, then you will clear like this. So this will be more like something like a mark and meet kind of a technique, where you can have one area here and then start from here and meet here. Then
Okay.
slowly you can start in the center, inside out. Start from inside, move towards the left, then again come to the inside, change your blade, move towards your right. Or you can also do outside in technique, but outside in I don't prefer. Either you mark and meet technique you do, or start from exactly opposite to you, move one half, turn the blade, then move the other half. Yes, ma'am. Sir, good evening, Gaurav sir. I think I can see Gaurav sir. Good evening, sir.
Hi, Prasanna.
Hi,
Good
sir.
to hear from you. That was a very nice description. I'm sorry I couldn't join earlier. I got
No
delayed
issues,
in the
sir.
OT.
I'm
But
happy
I
you
hope
were.
you guys had a very productive session today.
Yes, sir.
And
Yes, sir.
just wanted to pop in to say hello to everyone. And we are quite excited to see you all in Dehradun next weekend. And it's perfect weather, very nice, and good venue too. So please carry on with the discussions.
Yes,
I'll
sir.
keep
Yes, sir.
listening. Okay.
Yes, sir.
Great.
Thank you. Thank you for the opportunity, sir. We had a good, very one-on-one discussion. I think all candid talks which we don't have in conferences. That I
Right,
think
right.
these are all
Lots to
the.
learn from you, always.
It's my pleasure, sir.
Great.
Thank you, sir. Thank you.
Okay.
Hi.
Yes, yes, sir. Tell me.
Yeah. Last few questions. How many clock hours do you plan to take in, with KDV or bang? And is it possible for angle closure kind of cases where you can do this same therapy? And what would you say is your success rate in terms of when would you classify your surgery to be successful or not?
Yeah.
At whatever time frame.
Yeah. So it's very simple. I mean, I'll answer one question at the other. So how many clock hours, since I most of the time I use a TVG lens, I gain access to, sometimes 180 plus 20, 200 degrees if I'm lucky, even 220, because I have this docking mechanism. So I open a V like this. It's almost 180 for me, minimum 180. I do my KDB and band, one. If it's an angle closure, what I do is I take a small iris spatula, slightly near to the mid periphery. I just do a small dip like this, and the synechiae breaks. I do a goniosynechiolisis, and once I do a goniosynechiolisis, you will see the trabecular meshwork seen below, and then I do the similar one. So always an angle closure. If I have decided to go ahead with MIGS, I combine it with goniosynechiolisis, and a simple iris spatula or a Kugler Sook also sometimes really works. Iris spatula is more safer, and it really works well, or even a cyclodialysis spatula will really work well. Just to release the iris synechiae and then start doing the same. How do I rate it as a success or not? So I decide that this is going to be a particular target intraocular pressure. I follow the WGC guidelines. There is this complete success and there is this qualified success definitions. I'm not going into the theory. So complete success is your target IOP is reached without any AGM after your surgery. So if I am fixing, for example, 16 as my target IOP, if I'm getting that without any AGM, then it's a complete success. And if there is going to be a scenario where I have to put the patient on one AGM or two AGMs, and then still I reach my target IOP, that is called the qualified success. So these two define my success. So success is ultimately the intraocular pressure that I want to prevent progression, which is my target IOP. So if I'm getting my target IOP without any AGM or with a certain amount of AGM also, it is success. When will I define my mixed surgery as a failure is I'm not able to get the target IOP with or without medication post-op. That is going to be my failure. So that's how I classify it. And any surgeries in the world glaucoma consensus, these are the three definitions: complete success, qualified success, and failure. So that's how I would rate it.
I would like to ask once again if there are any further questions because we are about to close the meeting.
I think
What
we
we can
have
do, madam?
one question by Akshay Deep. So you want to ask that question, Akshay?
Yes, sir. Good evening, sir. Sir, actually, I wanted to ask, first of all, as you have already explained
I
that,
think yesterday we discussed this case, if I'm not wrong.
no, sir, that was different
Different.
one, sir.
Okay, okay, okay.
First, this was, sir, today there was a case of unicular patient 6'9" vision with the AT of about 10 and on a brimonidine and timolol combination for 3 months. And the fields are showing inferotemporal defect which is following Anderson's criteria. And in OCT RNFL, there is also superiotemporal thinning with the ganglion cell complex showing thinning to superior inferior field. So in such a patient, like on follow-up, if the field shows progressive changes, so can such patient be as an candidate for a MIGS or not, in your opinion, sir?
This patient, despite the patient having an intraocular pressure of 10, the glaucoma is progressing.
Yes.
So
Yes, sir.
I would think in terms of trabeculectomy for this patient as my
Right.
first line of management. If at all, the other eye is doing well, the other eye is well, fine, there is no issue with the other eye. If at all I contemplate MIGS, the only mixed surgery that I will contemplate is suture GAT, gonioscopy assisted transluminal trabeculotomy. But mostly 70% I'll keep it trabeculectomy. 70 to 75% my choice of surgery will be trabeculectomy, CARES trabeculectomy. Second would be the 30% or 25% I'll think in terms of suture GAT. If the other is, fine and doing well, because IOP is 10 and the patient is progressing, straight away
Yes, sir.
I would be having a cross for MIGS. Because had you told the IOP is 10 with two medicines and the patient is not progressing, you are telling,
Yes, sir.
following up the patient for 5 years, IOP is 10, patient is doing well with two medicines, the patient's glaucoma profile is stable, the glaucoma damage profile is stable, then 90% I would think in terms of suture GAT, and then 10% I would add trabeculectomy. But since you told that there is a progression, my line of treatment is going in terms of trabeculectomy, because I will not have an extra time, I do a suture gad, then analyze whether that is controlling. Even my suture gad IOP comes to 10, I'm still not confident, right? So in those angles, I would think in terms of another school of management is how is the IOP fluctuation? There are not many studies to report that. Meaning, how much of fluctuation does alter? Meaning the patient could have an upper IOP of 16. We never know unless you do a DVT. So I would go for a TRAB mostly in this case. Yeah.
And
So,
sir, like I am performing like FICO through a 2.8. So do I need to shift to like 2.2 clear corneal incision? So it is not required as you have already explained. Okay. Okay, sir. Okay, sir.
So thank you all for asking so many doubts, and I cannot thank Prasanna sir for like he had taken out time so in a short notice. Just 2 days back, I just messaged him, sir, please be there for us, and thank you, sir, for elaborating each and every point, and like each and every point has like a golden pearl for which has to be followed. Like each if you want to master your surgery, and sir has, I think so, clarified all the doubts. Still, our WhatsApp group is live. Please do message all the doubts in it, and sir will be more than happy to reply in those group in the WhatsApp group also. And we'll be having more talks by other speakers and other faculties in the coming online classes, as well as the physical meet we are having. The idea behind these classes is to keep you oriented about what we are gonna have during the wet lab session, because at that time it will be so much fuzzy, like you cannot have the doubts also there being clarified. So let's clarify all the doubts and all the short things which you have to be focused, and we'll be only focusing on the physical part during the wet lab duration. So this is a one of a kind concept which was started by the UC group, and one of the UC is taking up this thing in all the wet labs. If I'm not wrong, sir, like UC
Yeah.
has started thing.
We did
So
one
I'm very
we did one in Trichy also, where similar to this. Yeah, and
yes.
it's nice to see you taking it forward along with
So all
Amardeep
my ideas
ma'am
from you only and the UC team,
and
Dr.
Amardeep
Divya.
ma'am and Gaurav sir to support
Thank
all young
No, thank
ophthalmologists.
you so much, Dr. Prasanna, because I don't think there could be a better session at the introduction session or intro of gonioscopy. It was amazing.
Thank you, ma'am. Thank you, ma'am.
Yeah, thank you so
my
much.
it's my pleasure, ma'am. Thank you.
Thank
Thank
you.
you all the participants for the active
Thank you,
participation.
everyone.
Thank you. Thanks a lot.
Thank you.
Thank you, ma'am. Thank you, Shivam. Good night. Good night, all. Thank you.
Thank you, sir. Thank you, sir.
Yeah,
Lots.
yeah.